I'm Julie Levinsky. I am the Associate Digital Director for the Reeve Foundation, and I want to welcome you all to this webinar on depression and mentoring webinar. And we appreciate you taking the time out of your busy lives to attend this very important webinar. As you all know, because many of you have told us that mentoring peers who are experiencing depression can be challenging and overwhelming. Mentors wonder how to tell when a peer is depressed, what to say and not say, and how best to help. As part of the Peer and Family Support Program's Community of Practice, our new continuing education initiative for our mentors, we are pleased to offer this webinar that will address depression within the context of our peer-mentor relationship. Dr. Dan Gottlieb, a practicing psychologist and family therapist who is also living with spinal cord injury, will discuss the experience of depression, its signs and symptoms, the occurrence of suicidal thoughts, strategies, and do's and don'ts for helping peers with depression, and more. Following Dr. Dan's presentation, there will be time for mentors to ask questions and share their thoughts. You can always use the chat box too to share your thoughts and ask any questions. Now I'd like to turn it over to Dr. Dan. Hi, Dr. Dan.
Julie, hi. It's good to be with you again.
Yes.
And to those listening, it's sure good to be with you. And like Julie said, I do appreciate you taking time out of your schedule to attend this webinar with me. So I know you've got a lot of questions and issues you want me to address. So therefore, I'm going to tell you now that we are not going to wait until after my talk to get questions and answers, because I'm going to ask you throughout, and I'm going to need your guidance about what you want and what you need throughout. So please be open to sharing thoughts, questions. I'd also like to hear from cases you're working on that might be relevant where you could use help. So I want to go to what happens to us after a devastating accident. So when I was bedside, people said some extraordinarily stupid things to me, and I assume they did to you also. You know, don't give up hope. Maybe one day you'll walk. You shouldn't be depressed. You should be happy that it's not worse. I mean, all those things, just all those things. And so one day, I'm there, and all those comments just made me feel even more isolated and more lonely when people tried to talk me out of my depression or grief. And then one day, my cousin came in the room. We were alone. He looked at me, and he started to cry. And he said, I have no idea what this is like. And then I cried, because he's the first person that looked at me and had the courage to wonder about my experience. So what did I really need? That's what I needed. I needed compassion. It's the same as you did. It's the same as we all do. I wrote an article years ago about 4 words that I thought would change the world. And those 4 words are, tell me your story. Tell me about your life. What's the world look like through your eyes? And I'll sit here and listen. I'm not going to jump in with something I think I should say or something I think might make you better. I'm going to sit and listen. And I don't know, most humans I've ever met, that would be helpful for. So I want to know what would be helpful to you. What are the things that you struggle with and give you anxiety? If you could just type that in to the message box, or call him, or unmute your phone. But I would like to know. And if I don't hear from you, I'll just push on. I do want to say, while I'm thinking of it, that two people chimed in about non-Western interventions for depression. I think it's a great question, and I'll get to it when I start talking about depression. All right, so I've got another one I'm going to read now. He says, if I have a peer who seems distraught, anxious, angered, and possibly signs of depression, and states he feels his doctors have his many diagnoses incorrect. Besides trying to answer his many concerns and offer resources to assist him, I've told him about Boys Town and gave him the number in case he felt like he was going to hurt himself or someone else. How else can I show my compassion besides listen and try to provide resources? Well, Todd, I would say the same thing to you, that those 4 words, even when you fear someone's suicidal, those 4 words, what's it like? And, if he's making noises that he's suicidal, ask him why he wants to end his life. Most people who want to end their lives do so because they just feel that they can't tolerate the pain. All the issues, of course, the finances, the relationships, all of it, the whole package. But what it boils down to in terms of our individual experience is pain. Overwhelming pain. And we can't stand it anymore. And that's why most of us want to end our lives. Now, not all of us. Sometimes it's dangerous. I would say one other thing to you, that Boys Town only deals with young people, with children. There is, and I'm going to list the resources later, but the American Foundation for Suicide Prevention is a much richer resource, and they can tell you and your mentee about depression, about suicidal thinking or plans, about what the resources are that are available. And of course there's an 800 number too. So I'd highly recommend that. But don't worry, you're going to get that in writing towards the end. So let's talk about first the relationship. And it's important for you to keep in mind, and this might have been part of your training, but you're neither psychologist nor BFF. You are simply a kindred spirit, a guide who's been there, and someone who cares. There's no problem with telling your story, and it often helps, but don't use your story as a way of saying, I did it, you can do it. Because your story, your experience is your experience, And what you've learned may very well be helpful for your mentee, but may not. So, share your story. Share your story when it's relevant, and that's what I'm going to do here later on throughout the discussion. Share your story as it's relevant. And if you can get a sense in this relationship, if you're mentee, that you are kindred spirits, fellow travelers, you've done a great service for this person. So, towards the end, I want to talk about caring for ourselves. And I'll just give you this spoiler alert here. One of the biggest causes of burnout is when we expect ourselves to do things we cannot do. And I would imagine a lot of us are guilty of that, especially, when we're facing this great suffering. We're expecting us to do something or be something that we cannot do. I remember years ago, many, before my accident, I was on one of these daytime weekend TV shows where there was a high school kids were the panelists, and I was being questioned. And my expert way back then was drugs and alcohol. So they were questioning me about that. I brought my wife because it was a big deal at the time. So she's sitting with the engineer. One of the kids asked me a question, and I said, gee, I have no idea what that answer is. I said, give me your phone number, and I'll do my research over the weekend, and I'll call you. So I didn't think anything of it. My wife tells me the engineer was blown away because all these experts, he told her, nobody had the courage to say, I don't know. So it's an important lesson for all of us as mentors and as humans, but it's okay to say, I don't know. It's okay to say, let's do this together. Let's try to figure it out together. So let me pause here. Any questions so far? I see T.J. Griffin has a question, and I will get to that. But anybody else? You want to unmute your phone?
And as a reminder, that is *1.
Thank you. Okay. T.J. Griffin says, dealing with the future is always tough on new injury peers because they still look to the past of what life used to be. So, this is where I was going with my presentation anyway. What is the difference between grief and depression? So, and, a post-traumatic reaction also. So, I lost my mouse. So, let's talk about the initial weeks and months after the accident. I was in physical shock after the accident, but that lasted a couple days. But the emotional shock, psychological shock, took many months. I remember the first 3 or 4 months in every one of my dreams, I was walking. And then I'd wake up and I'd be depressed. And I noticed that 6 months or so after the accident, there would be something wrong with me. My legs would be weak. I wouldn't be able to walk, but my legs would be weak, or I'd be limping or something like that. And I was aware as a psychologist that I was beginning to make this transition. So the psychological shock, lasts for a much longer time. And T.J. Griffin, this might be part of what you're seeing. Of course we look to the past. That's all we have, is the past. And, that's where the pain is. We always go back to where the pain is. I mean, it's an adaptive part of, how we function as humans. Pain demands attention. And there the pain is in the past. So in the short run, I wouldn't worry about it in the short run. But, you don't want to shift from past to future so fast, because what's going to get us out of this pickle, and most pickles, is to deal with what's happening right now, right this minute. Your mentee, is sitting there with someone who cares about them. So I wonder what that's like. I wonder how comfortable they feel in the chair or sofa or wherever they are right now. What's happening right this minute? And if it's anxiety or anger or resentment, that's okay. But that's what's happening this moment. The past isn't, and the future isn't. And God knows the future is unknown for them, for all of us with spinal cord injury. T.J. Griffin, tell me if that was helpful for you, and if not, I'll try to develop those ideas further. And anybody else, chime in. So we'll talk about, what happens shortly after. I was filled with anger and fear and self-pity and hopelessness and fear and helplessness and fear. I mentioned I was scared out of my mind about what was happening and what might happen, and I felt useless and worthless. And I would also imagine that many of you had those feelings. And I didn't feel safe enough to share all of these feelings. Afraid somebody would try to talk me out of them or tell me why I shouldn't feel them. But I felt them, and I kept them to myself, which of course makes everything worse. I suffered so much, like you, but I couldn't cry. I was afraid to cry for fear that I wouldn't stop. So I just didn't cry. And I felt depressed, the emotion of depressed. We all feel depressed after a great loss. That doesn't mean we are depressed. I also had suicidal thoughts for like the year after my accident. And we'll talk about that as things progress. It doesn't mean I was suicidal. It means I was in that category of I didn't know if I could live with this. I didn't know if I wanted to live with this. One of the things that helped get me out of it is I told my family, my adult family, not my kids, that I would give this 3 years. And then I'd make a decision about life or death. And, I became aware we were getting in the neighborhood of 3 years. And I took myself to a place where I could be alone. I think it was in my bedroom. And I just reflected, over my life and whether I wanted to live or die. And I chose life. And I told myself I chose life because I had 2 little kids. I chose life because I had a wife. I had parents and a sister at the time. I chose life for all those reasons. But it turns out that's true. But there's much more than that, too. I chose life because I don't want to give up this life permanently. Despite all my suffering, I had love in my life. People loved me. And, I knew they did. I couldn't feel it because I felt so useless and worthless. But I knew I was loved. So I chose life. And I wouldn't suggest this of you, but when I work with somebody who has these suicidal thoughts, I just ask them, do you feel like you're going to take your life this week? And they'll say, often, no. And then I'll say, why? Why did you choose to live another 7 days? And then you get the answers. We don't want to die because we love having a life. And most of us are not aware of it. And this is critical. And for us, I'm strongly suggesting you don't use that kind of intervention with a mentee. But it is good to keep it in mind. This whole business of choosing life, it's so important and it's so helpful. So let's talk about grief. The loss we felt is a death. Make no mistake about it. It is a death. And it's not just a death of bodily function. It's the death of dreams for the future. It's the death of our definition of what it means to be a man, a woman, a father, or mother. It changes our definition of who we are. It can be the death of a relationship. My marriage broke up after 10 years. No, we have experienced a traumatic death. So, what is mourning? Well, you all know what it feels like. My dreams, what I called my psychological shock. That's mourning. That's grief. And you heard through my dreams how I gradually was able to release my grasp on the past and open up. So that's what happens with grief. But, someone in grief, like you and me, feel depressed, feel the emotion of depression. But that doesn't mean we are clinically depressed. Often with grief, there's a loss of appetite. There could be spontaneous tearfulness. a loss of sleep, guilt, and often in our case, shame. And I don't know about you, but when I experienced shame, and I experienced it for years, it was, you'll excuse the expression, a crippling emotion. It causes us to beat up on ourselves, to hide, to think we're not good enough. So, in our case, shame, but not with typical mourning. With typical mourning, you'll see lack of sleep and guilt, and those feelings of depression in grief, they remit and then they come back. They go away and they come back like waves. So if you've ever gone to a wake or visit someone who's mourning and just spend an hour with them, you will notice that there can be tears and laughter within the same half hour. You'll notice that almost consistently. So the pain is there and it goes away. I remember when my mother died, my father said that he felt guilty because the other day he wasn't thinking about her constantly. And that's what we do. We hold on to the past and we have our definition of what we should do, how we should behave. So he felt that guilt about not thinking about her constantly, but, the following days and the following weeks, he didn't think about her constantly, and he developed his own life. He started dating again at age 85. So that's grief. And grief can trigger a major depression. Any grief can. The vast majority of people who've undergone loss or trauma has returned to baseline in time. So, if your baseline anxiety was about a 3, you'll get there. Or your depression or your happiness, you'll return to baseline, pretty close to baseline anyway. But if one has a history of depression or trauma, I had both. Or if they have few social and economic supports, there's a much higher risk. And this is a big deal. Social and economic supports. It really does affect the family. So, and that means, what insurance they have and if they have a supportive family, if they're in a significant relationship, that helps the prognosis a great deal. But here, I want to tell you something I learned many years ago. I had a decubitus that was pretty big. And I went to the doctor, and I was going through some very bad times in my life. And I went to the doctor, and he says, looking at the skin, he says, it's broken. And I'm looking at my heart and thinking, yeah, I know. He said, too much pressure. I said, yeah, I know. And then he wanted to cover it completely with something dark. At the time it was called duoderm. This is a long, long time ago with wound healing. And I said to him, wait a minute. I said, doesn't my wound need oxygen to heal? Why are you closing it off from the air? He said, your wound does need oxygen to heal, but the oxygen it needs is in your body. Everything your wound needs to heal is in your body. And if you can keep it clean, free of infection, and minimize the pressure. It's going to heal on its own at a rate of 1 millimeter a day. Now think about that. What about wounds to the heart? 1 millimeter a day. I wonder what that means. There's no medication for grief. There's no fancy psychotherapeutic interventions for grief. Now, if it is a complicated kind of grief, then we need treatment. But just for grief, what we need is companionship. Companionship. And, I've been implying this throughout, but I ask you to please not offer platitudes or try to talk them or tell them why they shouldn't feel what they feel. Like I said earlier, we all suffer. And when we suffer, we want to be with somebody who understands and cares. You don't have to say that I got through it, you can. They know that already. Who you are is much more important here than what you say. They're watching you. The same way I watched the people at McGee, my rehab hospital, who were ahead of me by a few weeks. They were my role models. I could see what could happen. And the volunteers at McGee, they were happy people. They laughed a lot. They hung out. And I thought, yeah, that could be my future. So who you are is much more important than what you say. So, come in feeling good about yourself, feeling some gratitude that you have this opportunity, how it can be so helpful to your mentee and yourself. We're going to cut back on those platitudes, and mostly, they come from anxiety. Look, the people that said all those ridiculous things to me, they were good people. They loved me, but they had all this anxiety. They felt they had to say something. And it happens to all of us. When you're sitting in that relationship and your anxiety goes up or your sense of helplessness goes up, we're inclined to say something to the other person that maybe we'll regret because we're acting out of anxiety and not compassion. So healing is almost impossible in isolation. I say to people, when I'm in a dark hole, I want somebody who loves me enough to sit in there with me and not stand on the outside and tell me there's light out there. So what I'm asking of you here is very, very difficult. Listening with a curious mind and open heart. It's very, very difficult sometimes. So, I want to open up here again to questions. Please chime in. Unmute your phone.
We do have someone.
Yes.
I'm sorry, we do have someone in the queue.
Okay. Is that Cindy?
Yes. No, this is
Hi.
Barbara.
Barbara, hi.
Hey,
Barbara.
yeah. Listening to you very much, and it's so hard, and I love what you said, because to me, being a good listener and, being who you are and just to be there with them, I think is important. But the struggle for me is how to help them get out of, maybe they've made some bad decisions that they maybe can't go back and change, and, like with relationships and things. And, how do you give them hope to move on?
Yeah. You're talking about regret and remorse. I call that, and you can use this label. It might be helpful. I call it the persistence of the impossible. And you know damn well it's impossible, right, to change your history.
Yeah.
And yet it stays,
Yeah.
and yet we can't let go of it. Giving someone hope, boy, that's a double-edged sword here, because giving someone hope gets right back to, let me tell you how to feel differently. I think we're going to get to this towards the end. Perhaps taking steps to happiness. You can ask them to visualize one day or 1 hour when they're feeling joy. Spinal cord injury or not. Just picture 1 hour when you're feeling joy. And if they can, you can build on that or come back to that over and over. Next time you come, give me another hour, a different hour where you can experience joy. I use, I don't know if it's appropriate for you guys, although it might. I have my patients send me an email. I've got one guy who sent me an email every day with what he's grateful for. It's really changed his life. So, you can have them send you an email when you're not seeing them, or phone call about what's that hour look like. So, hope for the future comes when you can experience some joy in the moment. And, that one experience of joy. I remember after my accident, about a year and a half into it, no, a year, I remember hearing myself laugh loud. And I thought, what the hell was that? I haven't heard that sound in a long time. But there was that moment when I experienced joy. And that really recalibrated an awful lot of my mood. So, that's one way of doing it. See, hope can cut both ways. See, hope can be a wish that may or may not be realistic. And if it's just a wish without a plan, then you remain in a helpless position, waiting. It's like somebody who's waiting for their mother to change her behavior towards you, or their spouse to change, and just waiting and hoping and getting pretty PO'd when it doesn't happen. Real hope is almost like a goal. What do you want to see happen for yourself? Realistically, what do you want to see happen for yourself? And then, what's the plan? How are we going to get there, and how can I help you? So that's the kind of hope that is really constructive. It's energizing, and it puts your mentee in a powerful position rather than being passive. Are you understanding?
Yes, that's good. But like you say, you can't give people hope because, they have to find their hope. And I think that's a good way to say they need to plan. You just can't hope and wish. You have to make plans and move forward and not dwell on, could be some bad decisions you made, but you need to leave them behind you.
I wrote my most recent book, now a couple of years old. It's called The Wisdom We're Born With. And you talk about hope. See, here's the essence of what the book's about. An infant, toddlers, they have joy, they love without condition, and they love easily. They don't fear someone hurting them. They have faith. They are able to experience awe, AWE, in any moment, every moment. And they have it all. They have it all. And that includes hope. They all believe that, to the extent that these young brains can, that the future is good, unless they've had a, early traumatic experience. But you want to know where hope is? It's inside of you. It just went underground because of the traumas of your life. But it's in there. Question is, how do we find it? But it's in there. And, that's my approach to my work also. It's in there. So,
well, what helped me most after my injury was my grandchildren, because children are in the moment. My granddaughter was 5 and my grandson was 3, and I still got to color with them, read books, do all the general things I did as a grandparent previously, and they're so much in the moment. They weren't like adults, and that really gave me so much pleasure and relief. And then a few years ago when my granddaughter was here staying with me, my husband had a commitment. He was out of state. And I just got a little teary-eyed, and she said, "What's wrong?" And I said, I never expected to ever have to ask my grandchild to put my shoes on me. And it just made me all teary and emotional. And she looks up at me because she was putting my shoes on, and she says, "I don't know why you feel that way. You're Cinderella every day." And that just stuck with me and just really made me smart.
Isn't that great?
Yes, children are great.
So there's a future therapist for you, which is good news and bad news. But there's one other thing these grandchildren did for you. They got you out of your own head.
Right.
That is critical. Your mind turned to other.
Mm-hmm.
And I'm going to talk about that at the end, when I talk about cultivating happiness. Because somebody had sent in an email earlier wondering about that. So if I answered your question, I'm going to go on to depression. But I really appreciate your question. I really appreciate your courage in being the first one to call in. So thank you. And if anybody else has any questions about, grief, mourning, even, this ideation of feeling I can't deal with this anymore. Okay, or type in a question or comment. And by the way, I'd love to hear you talk about any cases you're working with that you're having difficulty with, because that's probably the best way to learn, is doing it in real time and not with these abstract concepts. Okay, so depression and what it is and how it's different from a depressed mood. So we're at risk for depression nationwide. In any given year, 17% of people are experiencing a clinical depression. Ours ranges from 20% to 40% of us could experience a clinical depression. Now, I'm going to tell you what it is, and there's several kinds of depression, and they're important for you to know also. So, sure, depression is having that sad or depressed mood, the same as grief. But it also includes a lack of interest or pleasure in activities once enjoyed. Of course, we have to work around the spinal cord injury and the functional issues, but just lack of interest in pleasure or any activities. With depression, we often see changes in appetite. So people with depression tend to either overeat or undereat. They put on weight or they lose weight, and that's outside of their intent, their diet. And it's the same thing with sleep. People with depression often either can't sleep or they sleep too much. It's called hypersomnia, where you'll hear someone with depression just say they want to stay in bed all day, and unchecked with a more moderate to severe depression, that's what they'll do. They'll just stay in bed all day. Lack of energy and fatigue. You look at lack of emotional energy, because lack of energy goes with spinal cord injury, or fatigue does. So especially higher level spinal cord injuries. But that loss of emotional energy is different. There's a sense of purposelessness with depression. Physical activity, you'll see that's different. Things like, for higher level spinal cord injury, you'll see hand wringing or picking at someone's hair, or, you'll see some symptoms indicating a sense of agitation. You might see change in movements or even speech, for that matter. The speech can become a bit slurred, or it can become racing speech, almost without taking a breath. So, watch, listen for all of these things, and feeling worthless or guilty, and certainly filled with shame. Now, some of these symptoms are consistent with our post-traumatic reaction. They're consistent with grief. But if you have all of these symptoms, or many of them, I think it's 3 or 5, then we got to think about clinical depression. People having difficulty thinking or concentrating or making decisions, that's a symptom of depression. And listen, as an aside, it is said that depression starts on the outside, and improvement starts on the outside. So someone outside is going to notice your depression before you're aware of it. I remember, I've got a history of clinical depression, and it was about 4 years after my accident that I slipped into a pretty deep clinical depression. I didn't know. I was having these racing thoughts, and I was scared to open my mouth, because if I did, then people would know how crazy I felt. And that's what I felt. I mean, I just felt crazy and scared. And I was driving, and my nurse was in the passenger seat. We stopped at a red light, and she just looked over at me, and she said, "Dan, you look like you have the weight of the world on your shoulders." And I thought about my emotions at that moment, and I said, I'm depressed. I didn't realize it until she told me. Now, I'm living with a woman for the last 10 years, and she knows way before me when the depression's coming back and when the depression is diminished. So we can't tell what's going on inside of ourselves often when we are depressed. Thoughts of death and suicide are pretty common with spinal cord injury as they are with depression. Thoughts. And we talked about, worthlessness and exaggerated guilt. But with spinal cord injury, we feel that. With clinical depression, these feelings are unremitting. They just don't go away. People with depression either don't return to their average activities or don't want to. So, let me stop here. We've got a question from Angela. She said, hi Angela, by the way. One of my ladies in her 50s is getting depressed because her husband doesn't want to sleep with her anymore. What do I say? She's about 2 years post-injury. Well, before I get to what you can say, if anything, you can ask, because in all likelihood, there was something, this was not a happy marriage before the accident. So, just ask out of curiosity, what was your life like in your marriage, before your injury? And what would you like to see happen in your marriage? Of course, a situation like this could benefit from couples counseling. But a couples counselor who's trained in marital and family counseling. Most therapists do it, but many are not trained. So if there's a way you could discuss the possibility, because, having one person sleep in another bed is kind of like purgatory in a marriage. It doesn't feel good. You're neither here nor there. You certainly don't want to spend too much time there. So at first, leave it at first. And then, it's time to bring up a discussion with her and encourage her to have a discussion with her husband. I hope that's helpful, Angela. Good. She said yes. Good. Okay. So, what are we going to do about this depression? Now, I'm not getting to. I've just covered thoughts of suicide. So let's first talk about depression. So what I experienced, even though I felt crazy and scared of my thoughts, and I was probably not functioning at my optimal limits, I was still classified as a mild depression because I did get up every day. I did function. I might have hated doing it, but I did. I got up and out and functioned. I ate meals normally. I might have done a little more carb loading, comfort food kind of things. But, still a mild depression. Mild depressions, most people start on medication, but that's not necessary. Psychotherapy has a better track record in the long run. Medication's great in the short run, but psychotherapy involves learning and cognitive changes. So, but again, make sure that you're dealing with someone who knows how to treat depression and knows the latest research on depression. So therapy is important, but who you pick is also important. Who they pick is also important. And a lot of people say, I need to see someone who's got a spinal cord injury who can understand. And I say in response, boy, that would be great. But I know way too many people. Well, no, that's not true. I know several people who have disabilities and who are therapists. And some of them are great. They have increased compassion and empathy. And some of them are just awful, like any other profession, and I've seen people who don't have spinal cord injuries that are open to learning, who are able to ask the question, what's it like? Educate me. And you will feel, or your patient will feel, as though they're with someone who really cares to know them. So keep that in mind. So let's talk about suicidal thoughts. Before I do get to that, now for someone with a more severe depression, talk therapy is not going to help, because talk therapy, is talk. It involves concepts. It's, we like to think it's emotional, but you get there through, cognitive activities, and they're not ready. They don't have the energy. The more severe ones, the ones who want to stay in bed, the ones who are losing or gaining a great deal of weight, who may be at risk for losing jobs or families. Talk therapy is not the first way to go. They need to be on medication before they get on psychotherapy. They need to be stabilized, and they need to be able to have their brains slow down and their bodies relax a little bit. And medication's a great way to start that process. Just for your own knowledge, I recommend to people that they go to their family doc first. They don't need to go right to a psychiatrist. But if the medication the family doc prescribes isn't helpful, then you need to go to someone who's more knowledgeable about these what's called psychotropic medications. And I know there's a lot of factors playing in here, like insurance per se, and other factors. So let's get to suicidal thoughts. When they become dangerous. So when they become dangerous is when they have a plan. And when they have a way of acting out that plan, then it becomes an emergency. So, I would talk to them privately, listen to their story, and again, it could be very uncomfortable for you. Please avoid debating the value of life. You have to first just listen. And then, if it's gotten to a point where they have a plan and a method, you have to enlist their family. It's critical. And if there is no supportive family, I strongly suggest that you sit with them as they call the suicide prevention hotline. You can't ask them or anyone with depression, you can't say to go find a therapist, because finding a therapist, A, involves screening, B, it involves finding therapists in your area who are competent. It involves finding someone who takes your insurance. Now, that's a pain in the butt for you and me. But when you're depressed, it's impossible. You've got no emotional energy to do that. So you have to lead them to resources. If they refuse to call the suicide hotline and they've got no supportive family around anywhere, I think it's time to either call 911 or tell them you are. Calling 911 is what happens if they don't. Because if they don't call the hotline. Because you don't want them to die because you care about these people. So tell them, you'll sit with them while they call the suicide hotline, or you'll call it for them and put them on the phone. But if none of that works, and tell them that you're going to have to call 911 just because you care, just because, they have a brain disorder now called depression. And we want to help their brains, which are ill right now. It's not them, it's not weakness, not any of that stuff. It's a brain disorder that has been created or reactivated by something on the outside. But, and also keep in mind, after you check out the resources below, and keep in mind there are public mental health resources in just about every county in the country, or most counties have a family service agency that they should know how to deal with emergencies. Okay, we talked about depression and suicide risk. There's got to be questions or comments here. So just take yourself off mute. What is that again? #1?
It is the star key followed by the digit 1.
Yeah, exactly. My memory is impeccable for about 15 seconds. So nobody has any comments or questions? So, geez, I hope I didn't put all these people to sleep. Well, if I did, rest easily. So let's continue. And we talked about mobilizing families if someone's just suicidal. But families need to be mobilized before that if they are around. Keep in mind, now the families might not be your responsibility, but having supportive family, having an intimate relationship is often make or break for people with spinal cord injury or any disability for that matter, because, we're social animals. And the research shows that sustained loneliness can be as lethal as cigarette smoke. So let's meet with the family. Let's get to know them. Let them get to know you. Ask if there's anything that you can do for them. Keep in mind, they have been traumatized too. Their lives are upside down also. And, if they weren't working and their partner or spouse was, they're overwhelmed with financial issues. And, that by itself can lead to guilt with some, depression with some. It can lead to anger and resentment. And, I wonder, resentment for who? But resentment for the change in their lives. And often, resentment towards their partner or their spouse. And I suspect some of that was going on with the person Angela was talking about, who was in her 50s and her husband doesn't want to sleep with her anymore. So, I suspect there's some anger or resentment in there. My wife was angry at me, and not consciously. It's not because I did anything, but it's because what I was no longer doing has changed her life, and she was angry. She felt betrayed almost. She would never had verbalized that, but that was the feeling. You were here, now you're not here. And it's not rational, but it is. So they need care. They need care. So just understand what they're going through and offer that kind of care for them. You're not a resource for them, but just care. And I just want to tell you that Angela and Todd were kind enough to tell me they're not sleeping. And I thank both of you for that. Okay. Any other questions or comments?
We do have a question on the phone.
Okay. Hello? Who's there?
Hello, this is Sharon. I was just wanting to thank you for this information because it has been very helpful.
Oh, I'm so glad it was.
I have a son that was injured a few years ago, and so hearing it is very helpful, the information you've shared so far. So thank you.
How long ago was he injured?
About 6 years ago from a football injury. About 6 years ago.
And was it a high school injury or college?
College injury from a football accident.
Yeah. How's he doing now?
He's doing really well. He's thriving. He's driving. He's continuing his education. And he started a nonprofit that, to pay it forward with other spinal cord injured individuals.
Well, I want to tell you and all of those listening about something that rarely gets talked about. We talk about post-traumatic stress, but what doesn't get talked about is post-traumatic growth. And how many people do we all know, including ourselves, that feel that there has been positive growth through this, increased compassion or self-confidence in learning how to get through this tremendous adversity and function again. Whatever it was, the majority of us have post-traumatic growth. Now, in my case, I have both. I've got post-traumatic stress. I've got an easy, quick startle response. I'm scared to death still scared to drive near 18-wheel trucks because that's how my accident happened. But I'm a different man. I wrote an article once that said I broke my neck and my soul began to breathe. I became the man I always was, and I'm afraid that wouldn't have happened without this. And I look at your son and look at him, post-traumatic growth. I'm so happy for him, and I hope you're enjoying his growth. And
yes, thank you.
Thanks so much for calling. I got a note from Kate Strickland. What if it's someone having serious suicidal thoughts that lives across the country without a support system? You can't physically be there for them. So do you have any advice to best be there for that person? Oh yeah, I do. We've got Skype, or FaceTime or whatever you use. If they can be set up with that. But connection. You could even, through Skype have dinner together or something like that. And ask about other supports that person might have, and set Skype up with them also. And you've got the same resources. There's the National Institute of Mental Health, there's the American Foundation for Suicide Prevention, and you'll see. If Julie, are you there? Because I've got it here. I can just post this, right?
You ready to post your links?
I am.
Ta-da!
Here we go. So, there's all these great resources. And boy, NAMI is a great resource. You'll see towards the bottom, National Alliance on Mental Illness is a great resource because they have programs all throughout the country, and they've got support groups throughout the country, and support groups are so helpful to be with kindred spirits. I mean, that's kind of what I've been talking about the whole time. Any good books? Todd Johnson wants to know. Oh boy, I should have done my research about that. There's one called and it's geared to patients and therapists, but it's the mindfulness way through anxiety and depression. And it's written for one of them is written for the layman. The other, the textbook, is not, and it's expensive anyway. I would also encourage you and your clients to take a look at a book written by Kristen Neff, Kristenneff, and it's called Simply Self-Compassion, which is something you need, especially in this work, knowing that, my God, sometimes you're in there and you suffer. You feel helpless or scared, or, you need compassion. You need compassion. And it's got to come from you. Todd, about books, I wish I'd done my homework. For some reason, I didn't think of it. Sorry. I want to address one last thing, and that is two things, actually. Non-Western medicine for dealing with depression, and I'm a big fan of that. I like preferably to go with things that have been tested and show track record. To wit, mindfulness, meditation, and yoga. I mean, there are libraries now worth of research showing its efficacy for depression, anxiety, and many, many other things. And if they want to take a course, or you do, there's online courses, or some in your neighborhood. But I'm a big fan of whatever they can do to get in their body. So there is chair yoga. I'm taking a course now on chair Tai Chi, and it's really interesting. I don't know if it's helpful yet or not. But so things that help them get into their bodies. There's no research on ointments and oils. There is some research on acupuncture, and the research that's out there, is good, especially for pain. So, those things, things like acupuncture, even though there's not a tremendous amount of research, to the extent of my knowledge, I don't believe they can cause harm. How do we promote positive efforts through strength? We talked with, I think it was Angela, about her grandchild. Oh, no, it wasn't Angela, about her grandchild. And I commented that what gave her joy was getting outside of her own head. And that's the problem with depression and anxiety. We just get lost inside our own head. And, my meditation teacher said, the mind is a dangerous neighborhood. You should never go there by yourself. So, my mantra is the path to mental health is through the pursuit of social health. And so go out and help some living, sentient being, whether it's an animal, whether you volunteer at a shelter, or get a dog, or help train a dog, or children, or an old age home, or even trees or plants. But just get involved in helping someone, something, anything, and just do it for a couple of hours a week. I strongly suggest that, and ask them about a positive experience they might have had, just for a half hour that day, and ask them to describe it to themselves and see if they can catch themselves having another one tomorrow and one after that. And most important here is a gratitude journal. If they can, just one a day, notice something they're grateful for and feel grateful. This whole thing can take 10 seconds and maybe even jot it down. That's great. Do that for a week. And then the next week, 2 items you're grateful for. And the week after that, 3. And that alone will change someone's perspective on life. So I hope this has been helpful for you. Barbara said that Reiki is great too. It's given me pain relief and positive inspiration. I'm not aware of any research, but I know an awful lot of people who use it, and it has given them pain relief and more energy. So there's that. So I hope this was helpful. And if anybody has any last questions or comments? Okay. I am going to, if you have any questions, any follow-up questions, please send them over to Julie, or and they will get them to me, and I promise I'll get back to you. So I really want to thank you all for listening and for getting involved in this talk. It's been a great joy for me to be able to offer you whatever I have in my head that might be helpful for you. So thank you. Okay, Julie?
Yep. Thanks, Dr. Dan. I appreciate it, and thank you to everybody that attended. And I'm sure someone from the Peer and Family Mentor program will get in touch with you to send out the resources page and also how you can reach out to Dr. Dan. So thanks a lot for joining us. Have a good day. Bye.
And that concludes today's webinar. Thank you for your participation. You may now disconnect.